Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club on CMV matching and kidney transplant is hosted by the AST Infectious Disease Community of Practice.
Welcome, everybody. I'm Jonathan Maltzman from Stanford University, and it's my pleasure to introduce Dr. Joseph Lockridge. Dr. Lockridge is currently an associate professor of medicine at Oregon Health and Science University, and he's also the medical director at the Portland VA Kidney Transplant Program. Joe completed his undergraduate work in economics at the University of Dallas, followed by his MD at the University of Texas Medical School. And after an internship and residency at UT Southwestern, he moved to UCSF for training in nephrology, followed by transplant nephrology fellowship at Stanford. He took his first faculty position at OHSU, where he was recently also promoted to associate professor. Joe's interests include post-kidney transplant complications, care of kidney transplant patients in the VA system, and of course, cytomegalovirus in transplant recipients. I've gotten to know Joe pretty well over the last 3 to 4 years, both through research and clinical arenas. In full disclosure, Joe is a site PI at a VA-sponsored multi-center trial of mine that focuses on immunobiology of CMV responses in transplant recipients. And he's, as the medical director for transplant at the Portland VA, we share a number of veteran recipients of kidney transplants as patients. In all of these ways, Joe has been energetic, thoughtful, and insightful. And now let me turn this over to my co-moderator, Jennifer Chow, to introduce the paper that will be presented.
Thanks everyone for joining. I'm Jennifer Chow from Tufts Medical Center and a member of the AST IDCOP Executive Committee. Today we'll be discussing cytomegalovirus serologic matching and deceased donor kidney allocation optimizes high and low risk D+R- and D-R- profiles and does not adversely affect transplant rates. So everyone in this audience knows that CMV infection and disease after kidney transplant continues to be a major source of morbidity and mortality. In order to prevent CMV infection post-transplant, Dr. Lockman and his colleagues sought to decrease the amount of CMV serologic discordance via a CMV serostatus matching program amongst 3 kidney transplant centers in Oregon. They were successful at reducing the amount of high-risk CMV D+R- and increasing the amount of low-risk CMV D-R- transplants. Furthermore, the CMV matching protocol did not adversely affect waitlist times nor transplant rates. I'm looking forward to hearing more about the details of this study from Dr. Lockman.
Thank you, Dr. Chow and Dr. Maltzman, for the kind introduction. And thanks to the Infectious Disease Community of Practice, AJT and AST, for the invitation to share our findings. So to start with some disclosures, I receive honoraria from Sanofi and Alexion, and as Dr. Maltzman mentioned, I'm the site PI for a VA Clinical Science and Research and Development Grant Fund. However, these projects are unrelated to the discussion that we will embark upon today, and thus I have no conflicts to disclose. So jumping right into it, CMV infection is something that we are all familiar with and all have to deal with. And really the model of infection, there are direct effects and indirect effects of cytomegalovirus. And the direct effects have to do with end organ tissue damage. And as you can see here, just about any organ system in the body can be infected and damaged by CMV as a direct result of viral inclusion. However, the indirect effects have less to do with direct tissue invasive disease and more to do with the postulated theory that CMV infection can induce an immunomodulatory effect on the immune system. That is a maladaptive and effective immunosuppressive effect on the immune system. And that can result in increased rates of co-infections of bacterial, fungal, and other viral infections, as well as increased rates of post-transplant lymphoproliferative disorder, increased rates of rejection, allograft dysfunction, and cardiovascular complications via the pathway of vasculopathy as demonstrated in animal models, as well as new onset diabetes after transplant. So the CMV has evolved in the transplant population, in the general population and the transplant population, to be unrecognized by the immune system, and the effects of this can be manifested through these so-called indirect effects of CMV. Just some natural history of cytomegalovirus. In the pre-antiviral era, CMV disease was quite common. Schnitzler and colleagues back in 2003 characterized the disease rate amongst all comers in solid organ transplant as 46%, mostly occurring early after transplantation. However, that was then. We live in the antiviral era now, and although the infection rates have diminished, they have not gone away, and late onset CMV has emerged, particularly as a problem in the high-risk donor-positive recipient seronegative group after prophylaxis. So what are the prevention strategies employed for CMV infection? Well, in solid organ transplantation, there are two. There's prophylaxis and preemptive therapy. And prophylaxis and preemptive therapy do have limitations. Prophylaxis with antivirals does confer higher rates of drug toxicities and drug costs with the antivirals, and late CMV infection and disease can be common, particularly in the high-risk recipients. Whereas preemptive therapy or a test and treat strategy can confer higher rates of patient and graft complications. In this scenario, clinicians are willing to accept a certain threshold of CMV viremia, but again, the indirect effects of that viremic response can result in the indirect effects of CMV manifested clinically as things like increased rates of rejection and co-infections. Additionally, there are monitoring costs and implementation costs associated with a test and treat strategy. And so these strategies are limited. However, these are post-transplant prevention strategies. And prior to what we're going to discuss today, no pre-transplant prevention strategies have existed for CMV. Now, what are the risk factors for CMV? By far, the most common or most important predictor of CMV disease after organ transplantation is the serostatus of the recipient in relation to the donor. So donor seropositive, or I will refer to these as D-pos, D positives, and recipient seronegative, or R-negs, these patients have no pre-existing CMV-specific immunity. And thus, when they are transplanted with a donor organ that can carry virus, they are at increased risk of developing primary CMV infection. Additionally, the CMV seroprevalence in the United States in the general population is about 50%. But when you look at deceased donors and transplant recipients, that seroprevalence goes up to the 60s. So late onset CMV certainly remains a problem in the antiviral era, and late onset CMV is defined as the development of CMV infection after the cessation of prophylaxis. And the Mayo group looked at 176 of these high-risk profiles after prophylaxis for 90 days, and 29% of these patients developed CMV disease, not just viremia, but full-blown CMV tissue invasive disease. And also, these patients did suffer from the indirect effects of CMV, and they had a graft loss and mortality hazard ratio of 2.8 when compared with other seroprofiles. Other studies that have looked at the incidence rate of infection in the high-risk D-pos R-neg category have documented CMV disease developing in these patients anywhere from 20% to 50%. And those are certainly high rates of viremia. So in addition to the increased incidence in the high-risk group, these patients are also at increased risk of relapse and antiviral resistance, as well as being at increased risk of graft loss and mortality after CMV infection. And larger studies are starting to demonstrate that in this seroprofile. And there's currently no consensus among clinicians for how to prevent late onset CMV in the high-risk population. Now, conversely, the donor seronegative recipient seronegative profile, or D-neg-R-neg, have low rates of CMV viremia, so low that the guidelines recommend against prophylaxis with antivirals. And so this group is not exposed to the toxicities of antiviral prophylaxis, as well as the costs of antiviral prophylaxis. These patients are also at decreased risk of graft rejection when compared to other seroprofiles, and also at increased risk of patient, or they do have increased patient and graft survival compared to the high-risk group, as well as reduced risks of malignancy. The caveat there is that most of these data are from single center studies, and we really need more of an in-depth analysis of what the true incidence of the avoidance of indirect effects are in this seroprofile. Now, a year ago, a nice study came out of the Beth Israel Deaconess group addressing the research question, what is the differential effect of CMV serostatus on graft and patient survival? And what they did was they took 52,000 deceased donor kidney transplant recipients using UNOS data consecutively from 2010 through 2015 in the modern antiviral era. And these patients were subdivided into groups based on seroprofile. And this was the largest study of its kind, again, in the era of universal CMV prophylaxis to address this question. And what they found was that when you compare the high risk to the low risk group, that the low risk group had an increased risk of all-cause mortality at a hazard ratio of 1.18. And as you can see here, these are the unadjusted Kaplan-Meier survival curves for the low-risk group here in blue and the high-risk group here in red. They also detected a difference between these groups in graft failure as well as infection-related mortality. And again, this demonstrates the so-called indirect effects that can happen with CMV infection. And so back in 2012, my mentor, Doug Norman, and all of our colleagues here at Oregon Health and Sciences University and the Portland VA had enough of CMV infection and thought, well, what if we try to do seromatching in deceased donor kidney transplantation? And so this is a look at donation service areas across the country, and we are here in Oregon. This is our donation service area. Our organ procurement organization has 3 kidney transplant centers, again, Portland VA, OHSU, and Legacy Good Samaritan. And those 3 transplant centers bought into the concept that if we did perform CMV seromatching, we may reduce some outcomes in CMV infection. And so what was started back in 2012, that any time, for instance, a deceased donor organ would become available, we would test the CMV serology of the donor prior to transplant. And once we got the results of that donor serology, let's say it's a seronegative donor, in theory, that seronegative donor could go to a positive seropositive recipient or a seronegative recipient. So we decided to exclude a CMV mismatch and only put seronegative donors into seronegative recipients, and conversely seropositive donors into seropositive recipients. And the goals for that matching allocation was to reduce the high risk D+R-neg seroprofile, increase the low risk D-neg-R-neg seroprofile, and overall reduce CMV morbidity and mortality, as well as reducing the toxicity and the costs of antivirals. And so exclusions to the matching policy were employed to minimize potential disparities conferred by the CMV matching policy. And the most common was patients who were sensitized. We did not want to further disadvantage sensitized patients by requiring them to wait for a CMV matched organ. Additionally, we have not done this with zero antigen mismatches, directed donors, extrarenal transplants such as simultaneous heart, kidney, liver, kidney transplants. We only do this in adult deceased donor kidney transplantation. And very importantly, if a CMV matched recipient is not available on our match run, we will then that kidney will be offered to a mismatched recipient with the highest UNOS score. And as a result of that, deceased donor kidneys were not exported from our organ procurement organization as a direct result of the CMV matching policy. And thus, patients on the wait list were subject to the usual transplant access factors that determine transplant rates. Things like organ acceptance criteria, donor supply, the number of patients on the wait list. But the CMV matching policy had negligible material effect on deceased donor kidney transplant supply and demand, which I hope to show you with the following slides. So in our analysis, we went back and compared the allocation of deceased donor kidney transplants at all 3 transplant centers. We looked 27 months prior to the implementation date of September 1st, 2012. Those are the pre-group, and 27 months after the implementation date. And we looked at consecutive transplants in both the pre and post period. These are the baseline characteristics of the patients. And as you can see here, there are some differences in sensitization rates pre versus post, as well as some differences in the blood group, particularly blood group A, that were in the pre and post group. And what we found was that prior to the CMV matching policy, D+R/neg high-risk profiles made up about 19% of our cohort. As well, about 12% were the low-risk D-neg/R-neg cohort. And we reduced the high-risk cohort from 19% to 2.9%. And we increased the low-risk patients from 12%, almost doubled, to 24%. And we looked back and compared this to national data using SRTR, and the numbers in our pre-group were similar to the numbers nationally of 65,000 kidney transplant recipients in terms of the distribution of high risk, low risk, and then R-pos recipients. So who are we doing this for? Who is the major beneficiary of this allocation scheme? Well, it's the seronegative recipients, the R-negs. And this is just a blown up look of the previous graph of the high risk group and the low risk group. So imagine if you are an R-negative, a seronegative recipient on the wait list in the pre-era, and this is consistent with national data, you had a 60-40 percentage of getting a seropositive donor, and thus putting you at risk of the downstream perils of having a high-risk sero profile. The 6 months of valsite, the 20 to 50% chance of getting CMV infection after prophylaxis, rejection, graft loss, mortality, infection-related mortality. But as you can see, after the CMV implementation, that risk was reduced from 60% to about 10%. And so patients had a 90% chance of getting a low-risk kidney along with the lower rates of infection and avoidance of the indirect effects of CMV. And so the question with any allocation policy change should always be one of justice and whether or not this policy change is adversely affecting access to transplantation. And the metric that we decided to look at was transplant rates among recipients and whether or not our transplant rates had been affected by this allocation change. So the transplant rate is defined as the total number of transplants performed in a 1-year period divided by, of any transplant center or a group of transplant centers, that number of transplants divided by the aggregate time on the waiting list for those patients transplanted. And that number, again, is that number we're judged by on our annual SRTR program report, and it's used as a surrogate marker for access to transplantation. And it's inversely proportional to wait times for recipients. And as you can see here, the transplant rates in our organ procurement organization are shown here in orange compared to nationally. And the CMV matching policy happened here. And as you can see, our transplant rates were not adversely affected by the CMV matching change. In fact, our transplant rates were almost double that of the nation back in 2013. And so when we adjusted these transplant rates in the pre-period and the post-period for the baseline characteristics that I discussed earlier, it turned out that our transplant rates prior to CMV matching were actually less than our transplant rates after CMV matching, albeit without statistical significance. And so our transplant rates were not adversely affected by this, which is, again, what we expected because the patients on the wait list were not adversely affected by supply and demand factors. This is a closed system, and as long as we're performing the same number of kidney transplants and not losing any kidney transplants out of our organ procurement organization, the transplant rates should not, all other things held constant, the transplant rates should not be affected by the CMV matching policy. Now, the other question one may ask is if an RNEG, a seronegative recipient, is waiting on the wait list and is effectively passed up by all of these seropositive donors, wouldn't they potentially wait longer in waiting for a seronegative donor to become available and transplanted? And it turns out in our analysis that there was not a significant difference in the wait times for seronegative recipients versus seropositive recipients after the implementation policy was enacted. Additionally, the CMV matching policy presumes a stable equilibrium of donor and recipient serodistribution. And a sustained disturbance in this equilibrium may certainly change the distribution of R positives versus R negatives on the wait list. So this is a graph over time of the wait list distribution of CMV serostatus. And these are the CMV seronegatives, 39% R-neg, 61% R-pos. And as you can see, over time, we did a trend test of our waitlist distribution and found a not significant difference between these years, indicating that a stable equilibrium was possible. And as long as that stable equilibrium continues, then we presume that there are no adverse effects of the policy with respect to transplant access. Now let's take a step back and discuss some of the mechanics of how we actually implemented this policy. So here you can see a match run that's generated by DonorNet with the UNO sequence number, the UNO score here, CPRA. And what we developed at our tissue typing lab is we developed a computer program that essentially takes the DonorNet match run, imports that match run, and then runs through that match run answering two questions. Is this a CMV match? And is this patient an exclusion for the CMV policy for the reasons that I delineated earlier? And then what that program does is it essentially plucks out the CMV mismatches and includes the exceptions, and then generates a match run for our organ procurement organization shown here. And as you can see, here is the UNO sequence number, here's the institution, ABO blood type, UNO score, etc. And as you can see, this donor is seronegative, and the recipients on the wait list, on the match run at least that we generated, are mostly matched for CMV serostatus. And again, there are exceptions, and as you can see, the exception here is because this recipient had a CPRA greater than 50%. Same thing down here. This patient had a CPRA greater than 50% and was thus excluded from the allocation policy. So sensitization was the most common reason why we excluded patients from the allocation strategy. So if you look here at the UNOS sequence on our OPO match run, what happened to numbers 1, 2, 4, 5, 7, 8, and 12? Well, if you go back to the UNOS match run, as you can see, sequence number 2 had a UNOS offer response of 802. So this patient actually was a simultaneous liver kidney recipient on the wait list. We did not want the liver from that donor, so that recipient was passed up. Patient number 3 was an 830 offer code, which has to do with donor organ quality. This patient happened to have a low EPTS score, so we went ahead and passed that patient up, as is commonly done, was commonly done in the pre-CAS era. But as you can see here, numbers 4 and 5 had the offer response code of 834, which is donor serology. We use this 834 code for CMV mismatches to effectively say thanks, but no thanks. We don't want these organs for these recipients. And the 834 code was historically used for donor serology, specifically hepatitis C serology, when in an era when hepatitis C seropositive donors were less utilized for transplantation, which is no longer the case now, certainly much less commonly than it used to be. Similarly, number 7 and number 8 were excluded from our OPO match run because of CMV mismatches. So what this demonstrates is that this is a zero-sum game. There are losers, but there are also winners. The losers here clearly are number 4 and number 5 because they were passed up on the match run. However, the winners here are number 6, who got a kidney, and number 9, who also got a kidney, who were CMV seronegative and matched to a seronegative donor. Now, in any other system, number 6 and number 9 would have never gotten these transplants. And so again, the losers in this situation are 4 and 5, but the winners in this situation are number 6 and number 9. And the quantity of gain of these winners in green is more difficult to assess because it's hard to estimate how much longer number 6 and number 9 would have waited in a usual non-CMV matching transplant scheme. And so we've demonstrated that it's possible to perform CMV matching, and it's possible to reduce the number of high-risk patients and increase the number of low-risk patients. However, even more importantly is, are we affecting outcomes by this matching policy? And I'll share with you some unpublished data that we did not include in the analysis, but we are eager to publish soon because we think it's important in relation to our allocation policy. And what we are actively doing is we're looking at our patients in our cohort and doing chart reviews for CMV infection. And we divided, in the work that we've done to date, we've divided these patients who have gotten CMV infection between CMV viremia, CMV syndrome, and CMV disease. We utilized the help of one of our infectious disease colleagues to categorize all patients who developed viremia to see if they fall into the category of having CMV syndrome, which is viremia plus either symptoms or laboratory evidence suggestive of tissue invasive disease, versus CMV disease, which is defined by this paper as biopsy-proven tissue invasive disease. And so we thought that we'd utilize this definition for use in clinical trials just for reproducibility. And what we found, so again, these are unpublished data from the university hospital, and what we found was that patients with CMV viremia in the pre-period, we had 19% of patients develop CMV viremia. And this is fairly consistent with the Valcyte trials that have been done in the past detecting CMV viremia under the strategy of prophylaxis. After we did CMV matching, we reduced viremia rates to 10% significantly. For CMV syndrome, and this is even more important because these are the patients that we treat with antivirals. In the pre-period, we had 12.8% of patients develop CMV syndrome, and we dramatically reduced that to 3%. Now, finally, CMV disease was much less common, but it was also reduced from 4% to less than 1% in our cohort. And again, the incidence of CMV disease is low, generally because the practice is not common in our center as well as across the country to aggressively chase a biopsy. If you already have the diagnosis of CMV syndrome made, a biopsy typically will not change management. So shifting a bit to charges for prophylaxis and treatment, this is a look at the costs of treating or prophylaxing a high-risk D+R neg recipient. And our hospital charges $11,000 for 6 months of Valcyte. As well, we employ a surveillance after prophylaxis strategy where we monitor CMV PCRs every 2 weeks for months 6 to 12 after transplant. And the total cost just for monitoring one of these patients is almost $15,000. Contrast that, and we certainly haven't eliminated that, but we've significantly reduced it with the reduction in high-risk patients. Compare that to the cost of prophylaxis in a low-risk D-neg-R-neg, which is 2 weeks of Valcyte, which our hospital charges $21 for. And as you can see, there's a significant cost difference in theory. But well, what's the evidence? We actually looked back at our charts in the university system, and in the pre-group, we looked at the number of days of prophylaxis our patients were exposed to, and then divided them by the number of patients. And we reduced the prophylaxis days per patient by a factor of more than 2, from 77 days per patient to 32 days per patient. We also looked at patients who actually developed infection and how long they required Valcyte, 450 milligram dose equivalent. And we added those up to the prophylaxis days and then multiplied them to what the hospital charges for Valcyte. So in the pre-period, we spent close to $1 million just on Valcyte for both prophylaxis and treatment. And the cost per patient turned out to be $6,000, whereas in the post-period, we've reduced it to a reduction of $2,700 per patient, again, just for Valcyte. So the total savings per patient is $3,400, which may not seem like much, but if you were to extrapolate this to the 23,000 deceased donor transplants that are done on an annual basis, it would result in a potential cost saving to the US healthcare system of more than $78 million. And again, this is just for Valcyte costs. This does not factor in hospitalizations, cost of treatment, cost of clinical visits, cost to the patient, lost work and wages, et cetera. And so this is just looking at Valcyte dollars. Now, are there other benefits to CMV matching? In addition to the reduction in treatment of CMV disease, syndrome, and viremia that we've discussed? Well, again, antiviral resistance continues to be a problem in the high-risk recipients. Hospital readmissions, we would like to be able to quantify hospital readmission rates in the pre and post period to compare. Co-infections and infection-related mortality, as demonstrated by the large study out of the Beth Israel Deaconess group, again, that takes a large cohort to be able to study, in addition to rejection and medication toxicity of the neutropenia that's conferred by Valcyte. So limitations to our study: it is a retrospective analysis. The study was intentionally pre-kidney allocation system in 2014 so that we would not get bias from the allocation changes and the bolus effect that happened after CAS was implemented. We are looking to do a post-CAS analysis base and look at transplant rates as well as other factors for transplant access. These are all aggregate data. We did not subdivide these patients into groups, but it is an area for future investigation. So other areas to investigate, one question that we'd like to address is, how does the CMV seromatching program affect access to transplantation for specific groups of patients? That is, would a matching policy have an adverse effect on groups with underlying disparities in transplant? And we'd like to be able to see, so with any allocation strategy, you want to make sure that there's a component of justice and that you are not making patients with disparities worse off by your allocation policy. And that certainly needs to be confirmed. Additionally, donor quality between D-POS and D-negs may differ. And so the question then may become, are we putting the seropositive recipients at a disadvantage by excluding them from a seronegative donor who may be younger? And then finally, what would the widespread costs and benefits of such a policy be if implemented on a regional or a national level? And so I'd like to end with acknowledgments and thanks. It was a very large group. There's not enough time to list everyone individually, but particularly my mentor, Doug Norman. This is his brainchild, and all of the assistance with my colleagues from pharmacy, nephrology, infectious disease, surgery, as well as our transplant bank and tissue typing lab, as well as at other transplant centers. And with that, I'll open the field up to questions and discussion.
Fantastic, Joe. Thank you very much for an excellent discussion or excellent presentation. We've gotten a few questions already, and I'd encourage everybody else to write their questions into the chat tab. The first one is from Margaret Jorgensen, who asks, we are discussing using CMV matching at my center. However, I wonder, how do you manage the issue that evidence supports donor negative allografts having better outcomes regardless of the recipient serostatus from an ethical standpoint? Do you provide informed consent?
We do not provide specific informed consent. We in the form of a signature. We do inform and educate the patients in the pre-evaluation process about our allocation policy. You know, the question about the donor seronegative outcomes is an important one. And again, it makes sense for us to be able to optimize those seronegative organs into seronegative recipients. And this can be looked at as a surrogate method of age matching, which is in the spirit of the kidney allocation system. But certainly, as I mentioned in the previous slides, that we would like to do further analyses of how a strategy like this would look on a larger scale, so as to minimize disparities within organ transplantation.
Okay, I guess I'll ask another one. I've gotten a few questions that are along the lines of anticipating changes in allocation. Given the elimination of donor service areas potentially, how do you propose that we adopt the strategy in a national level or in another region?
That's a very good question, and we have certainly benefited from the local unit of allocation being our donation service area, because we can implement this strategy with relative ease. However, because the local unit of allocation will be disappearing starting in December, and as we move towards continuous distribution, we think that it will be much more difficult to use this policy on a regional level because we have other transplant centers that we will be competing with that we did not compete with, or we currently do not compete with under the current allocation rules. So what we are proposing is that the policy could be implemented on either a regional or national level into the UNOS kidney distribution and allocation system. And there are a couple of ways that it could be done. It could be done in a similar way that the distribution of ABO A2 kidneys have been codified into OPTN policies. And just so some historical background on that, initially a small number of centers recognized the safety and efficacy of transplanting ABO-A2 kidneys into B recipients to increase the organ pool size for B recipients. Initially, this practice was carried out on a small scale, but then the UNOS Minority Affairs Committee suggested that there be a national variance to allow the transplantation of A2 kidneys into B on a larger scale. And then that was further implemented into the kidney allocation system in 2014. And now the allocation of kidneys from A2 into B are given priority. Now, the CMV sero matching would be simpler actually than the ABO-A2 into B because the serology is binary. It's either positive or negative and always available, whereas the allocation of A2 kidneys is dependent upon the anti-A titer of the recipient, which is a much more complicated measurement. And again, the CMV matching policy here requires the buy-in of every transplant center. But in addition to that potential model, CMV matching could be incorporated into models of continuous distribution by assigning sufficient points for a match in a similar way that DR matches were incorporated into the precast allocation system. And so we would need to carefully examine outcomes, economic analyses to come up with a score, an adequate score to be able to balance cost and benefit for such a matching policy. So I hope that it's a rather long-winded answer to the question, but again, it's something that we're certainly thinking of, and I think that if we wanted to continue to perform this allocation system, the way to do it is on a national scale.
Thank you. So to change topics, one of the questions was, what is the rate of lymphocyte depletion used at your center, and did it differ amongst the 3 centers in the study?
Very good question. Lymphocyte depletion is certainly a risk factor for the development of CMV infection. And as I showed you in the baseline characteristics for our patients, there was a higher rate of sensitized patients in our pre-cohort here, and those patients did get more lymphocyte depletion in the pre-group than in the post-group. And so when we formalize and finish our outcomes analyses, we will have to adjust for the lymphocyte depletion that was given to the recipients to see whether or not that had a significant difference on rates of infection. Protocols vary between, so OHSU and the Portland VA have similar transplant protocols in terms of management and induction immunosuppression. However, Legacy Good Samaritan does have a different protocol for induction immunosuppression. And so when we publish our outcomes, we'll probably have to separate those out between the 2 institutions.
A related question among the differences amongst the 3 centers. Were there differences either over time or amongst the 3 centers in how you approached CMV prophylaxis or preemptive monitoring?
So the nice thing about this study is that the CMV prophylaxis regimen between the 3 centers was fairly similar. What we used pre-CAS in this analysis was 1 month of Valcyte for intermediate risk recipients, that is all RPAS recipients who got non-lymphocyte depleting induction, basiliximab. Well, we use that for actually all comers, even patients who received lymphocyte depletion. We use 6 months of Valcyte for high risk and 2 weeks of acyclovir for low risk. Looking back at our data, it turned out our CMV infection rates were higher in patients who did get lymphocyte depletion. And so we extended the Valcyte from 1 month to 3 months back in 2015. And so again, once we publish those outcomes, we'll have to separate those analyses by prophylaxis regimens.
Joe, you touched on this with a previous answer, but I'm going to ask this one specifically. What do you predict would happen if this was scaled nationally in terms of the organ availability for CMV negatives? Would this become a disadvantage for maybe blood type B recipients?
Yeah, good question. I think that one of the things that we'd like to look at are what are the seroprevalence rates among regions across the country. Because again, the success of the allocation policy requires a stable equilibrium of donor serodistribution coming into the organ pool and recipient waitlist CMV serodistribution on the wait list. And if it turns out that there are large regional variations between donor seroprevalence and recipient seroprevalence, that may cause a temporary disturbance in the equilibrium. Now, there may certainly reach a steady state with time, but at least in our analysis, in our organ procurement organization, the steady state was, or at least the stable equilibrium was sustained, and the seronegative recipients did not wait any longer than the seropositive recipients in terms of waiting for an organ. And again, our serodistribution of CMV seropositive versus seronegative does fairly reflect the national composition of CMV serodistribution. About 65% seropositive, 35% seronegative.
Joe, have you guys had any experience with non-directed living donation in exchange using this strategy?
Yeah, so that's a good question. For non-directed donors, we excluded those scenarios from CMV matching. And in our living donor population, if a recipient brings multiple potential donors to the table, we will end up testing all of the donors and making an informed decision based on renal function of the donors, as well as CMV serostatus, and try to give the patient as an informed decision-making as possible with proceeding with the appropriate living donor. But for the most part, our allocation policy is limited to deceased donation. And I don't know if my colleague, Dr. Norman, has anything else to add to that question, or the question earlier posed about the possibility of implementation on a national level, and some of the historical background that led to the development of the allocation policy.
Sure. Happy to chime in here. With regard to CMV matching and living donor transplantation, we just felt that because of the limited supply of living donors, that it would be unsuitable to try to do CMV matching in that group, except in the case, as you point out, Joe, that a recipient has several donors from which to choose, which would be ideal. With regard to background, we recognized many years ago that high risk, that is D+R negative, was not good for older patients, patients with pulmonary disease or cardiac disease. So we actually implemented a CMV matching protocol for those high risk patients probably 20 years ago. And just trying to avoid putting positives into high risk, high medically risk D+R negative patients. We liked that policy so well that we actually implemented a CMV matching, that is R neg into R, or D neg into R neg for all patients. And the problem with that was that the waiting time for R negative patients essentially doubled. So to implement a policy of CMV matching, we realized that we needed to not only always exclude R D positives for R negatives, but we had to always exclude D negatives to R positives. So we had to really match, as Joe is putting up right now. And before we implemented that, we did look at the outcomes of putting D neg into R pos versus R or D pos into R pos. And when we looked at that at our center, we found that there was really no difference in outcome. So we didn't really think that we were doing, that we were disadvantaging our R positive patients by putting an R or D positive into them versus a D negative. So because of that, and because of the rather sort of equal distribution of CMV matching in our donors and recipients, that's what led us to implement this protocol in 2012. So just to summarize, we've been thinking about it for many years, and we felt that in 2012 that we could begin this protocol, and it's turned out to be really excellent. We feel like we've done a great service to all of our patients, and now the question is, how can we implement it on a national basis?
Thank you. I think we have one final question. Do you have any comment on how you could include CMV specific immune testing? I think they mean T-cell testing in transplant recipients in this allocation scheme.
Yeah, that's a great question. As you can see here, we've really enriched, as a result of the CMV matching policy, we've really enriched our D-pos, R-pos intermediate group to make up 65% of our transplant recipients. And we think that there is certainly a role for CMV T-cell specific immunity assessment in these patients, because as we're learning from randomized controlled trials and really with lots of different assays, that the ability to predict the absence or presence of T-cell specific immunity can be done. And so I think that with time, one of our next steps is to actually look at this in all of our pos recipients. So we certainly think that there's a role for that modality, and we're excited to implement it to further tailor and enhance our ability to assess whether or not these patients here shown in gray will get CMV in the future, and then thus allowing us to tailor prophylaxis or monitoring for those specific patients.
Well, thank you, Dr. Lockman and Dr. Norman. That was our final question. I thank everyone for joining us. Back to Brian.
Well, thank you very much, Dr. Chow. I would like to take this moment to thank Dr. Lockridge, Dr. Maltzman, Dr. Chow, and our guest, Dr. Norman, for joining us today. And thank you to all of our attendees. Please remember to complete the evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's infectious disease community of practice, please visit myast.org/COPS or connect directly to the IDCOP hub.